Good evening. Thanks for joining us for tonight's webinar. I'm Lauren Stiles, co-founder of Dysautonomia International and occasional POTS researcher. I'm not a doctor, so please don't take anything I say this evening as medical advice. The slides I'm presenting this evening were intended to be presented during our annual conference this past July, but I had the oh-so-wonderful experience of visiting the emergency room with a suspected blood clot during the conference. Thankfully, no blood clot, just some autonomic weirdness, which Dr. Shamali thinks would make a great topic for a future conference or webinar. Autonomic Weirdness 101. I'm sure many of you have experienced stuff like that where you're not quite sure if you should go to the ER or not. Well, luckily I was at a conference with a couple hundred doctors and they told me to go. So anyways, I've been privileged to work with some of the incredible POTS researchers at Vanderbilt University and the University of Calgary on what we've called the Big POTS Survey. It had a more formal title, but that's sort of the name that the patient community has given it. And this survey is the largest survey on POTS ever done. It's the largest study on POTS ever done, and it was designed and implemented with patients being part of the research process from the design stage to the implementation to the dissemination of the information we learned. And we certainly haven't figured out all of the differences between EDS, POTS with EDS and POTS without EDS. There's probably a lot more to it, but this is really the first study that tried to parse out, like, are there differences, are there similarities, and what can this teach us about both of these diagnoses? So to just jump into it. Also, I wanted to let you know, during the webinar, you can type in questions on your control panel, on which should be probably on the left side of your screen, and I'll try to answer questions that I can, and if there's questions that a lot of people are asking that I can't answer, I'll try to get you an answer from Dr. Raj at University of Calgary or one of the Vanderbilt research team members. So just to sort of jump into this, I'm going to assume that everyone on the call knows what POTS is, Postural Orthostatic Tachycardia Syndrome, and knows what Ehlers-Danlos syndrome is, EDS. Just really briefly, in case there are some folks on here who don't know what these things are, Ehlers-Danlos syndrome is an inherited connective tissue disorder, and it's actually more than one condition. There isn't EDS itself is just sort of like dysautonomia, is an umbrella term that includes a bunch of different disorders. So this evening we're going to be talking about Ehlers-Danlos syndrome hypermobility type, which is the most common type and the type that is most often found in POTS patients. POTS is an orthostatic disorder that is fairly common and probably under-recognized by the medical profession because it was first described in its current form in 1993, and that's fairly new in terms of medical knowledge. Although the research has been journal articles have been describing POTS probably as far back as at least the Civil War era, but it's probably been around since people have been on 2 feet. And it has a specific diagnostic criteria, which I'm sure many of you are familiar with, and there's more information on our website about it if you're not. So the next thing that we're going to talk about is, how did we do this survey? So this is the abstract that resulted. So the Big POTS survey actually was about 400 questions. So we're not talking about all of the questions in this webinar. We're just talking about the EDS symptom-related questions. It's so much data that it actually crashed my computer a couple times when I tried to open the data file from Vanderbilt, which is cool. I mean, no one has done really large POTS studies before, and this study had over 3,000 patients participating with about 400 questions. And when we first designed it, some of the researchers thought, oh, that's too much. There are too many questions. People aren't going to answer that many questions. And we said, let's give it a try. We think that POTS patients want to tell their story and are happy that researchers are asking them all these questions to sort of get the word out about what we really experience with POTS. And sure enough, almost everybody that started the survey completed it, because it, it was important questions. People were being asked about things that matter to their lives. So this abstract on EDS and POTS was presented at the Heart Rhythm Society in 2017, earlier this year. And the Heart Rhythm Society is where all the electrophysiologists hang out. And, there's still some doctors out there, even autonomic experts, who don't routinely screen for Ehlers-Danlos syndrome, or who don't even think it's relevant. And I know that's pretty infuriating for most patients. I feel like that is a real detriment to the patient. I think patients deserve to know whether or not they have it. And if your first doctor doesn't screen you for it, you're going to eventually find out from other patients that this is a pretty common thing in POTS, and you're going to go seeking out answers from another doctor. So I think it makes sense for doctors to screen everyone who has not only POTS, but also sort of broader category of orthostatic intolerance, to screen them for Ehlers-Danlos syndrome. And right now, the hypermobility type of Ehlers-Danlos syndrome doesn't really have a genetic test. There's a few very rare cases with a Tenation X genetic finding, but that's really not what most patients have who have Ehlers-Danlos syndrome. So right now it's pretty much just a screening, a physical exam and a family history and a personal history. So this doesn't take very long to do, and we think that all doctors who are diagnosing POTS and orthostatic disorders should be doing this. But doctors are slow to change their thinking, and sometimes they need to be prodded with evidence and proof that this is something they should be doing. So that's sort of what we set out to do, to collect data to see, does it matter if a patient has EDS or not? Now, as patients, of course, the answer is yes, it matters. But to sort of doubting doctors, how can we prove that it matters? So that's where we are. So I kind of reviewed already what this was. As many of you know, the Eds Diagnostic Criteria changed in 2017. There was a large update. And, anytime there's change, it's a little controversial. People are very used to what they're used to. But I think in the long run, the reason that the Ehlers-Danlos Society, who we worked with on this project, on the update to the diagnostic criteria, we worked on the cardiovascular autonomic dysfunction aspect of the large pile of papers that they published. And, the reason they did it is because they've done extensive research trying to find a gene that explains EDS hypermobility type. And nobody was ever able to pinpoint the gene, probably because the diagnostic criteria wasn't strict enough. So you get a lot of people with sort of similar but unrelated conditions, and then your genetic testing doesn't come up with any useful results. So they've made the EDS, hypermobile EDS criteria a little bit stricter, but they haven't left anyone without a diagnosis. If you already had a EDS hypermobility diagnosis, you would still fall under one of the categories, whether it's the new hypermobile EDS or some of the other EDS categories, that hypermobility syndrome categories that remain. Because their goal was not to leave any patients without treatment or without diagnosis for insurance purposes or other reasons you might need a diagnosis. So in our study, we just wanted to know if having EDS changes the clinical presentation of POTS in the broader community. A lot of the POTS research, all of the POTS research that has happened, has been on pretty small subsets of patients being seen at one of the autonomic labs, like 30 patients at Mayo Clinic or 40 patients at Vanderbilt, and there really haven't been any broad brush, capture as many people as we can. And we know as patients that we kind of self-segregate. If you think you have a weird arrhythmia thing, you're more likely to go see Dr. Grubb. And if you think you have some kind of hyperadrenergic thing, maybe you're more likely to go to Vanderbilt, because that's the centers that are sort of known for different things. So when they're studying POTS, they're not really getting a broad picture necessarily. But a survey, an online survey where we recruited through Facebook, you do get a really broad picture. The one drawback is that you don't have clinical verification that everyone who participated really has POTS. And so the one thing we kind of know that helps us sort of make that not such a big deal is when you have a huge cohort of 3,000 plus patients, even if there's 100 patients who didn't really have POTS or were inaccurately diagnosed, it's not really going to change the data that much. So we asked everyone who participated in the survey, have you been diagnosed with POTS by a physician? And everyone we counted the data from had said yes. And we also asked them, have you been to any of the major autonomic labs? And about 10% of the POTS population had been to one of the autonomic disorders consortium sites, which is Vanderbilt, Mayo Clinic, National Institutes of Health, UT Southwestern, Harvard, or NYU. And just for the record, anyone listening, the NYU autonomic lab really doesn't see POTS patients, so don't call them because you probably won't end up very happy if you go there. All right. The aim of our study was to characterize the similarities and differences between POTS patients who have EDS and those who don't have EDS. We had ethics approval, which is Institutional Review Board approval from Vanderbilt. It's a web-based survey. The official name was Diagnosis and Impact of POTS. We posted links through Dysautonomia International, through our emails, on our website, and our social media channels. You probably, if you were around on the POTS world in 2015 and 2016, you probably saw some of these, and hopefully you participated. It's actually still open if you want to participate, and when I send out the follow-up email for this webinar, I will include a link. If there's anyone who hasn't participated in the big POTS survey yet and wants to, you're welcome to do so. So our POTS population, we have a lot of prior studies on sort of these smaller groups of patients that say it's, 75% female, 80% female, 85% female. So this first really large study, we actually found that 96% of overall POTS patients who took the study, who participated in the survey, were female. And it was open to patients of any gender, any age, any geographic location. We offered patients under the age of 18 to participate through their parents. So as long as their parent was helping them fill out the survey, that was fine. And so we were kind of surprised that this was much more higher female predominance than previous, but maybe it could reflect a bias in Facebook. Maybe the Facebook groups are just more female predominant or more girl friendly, so the guys don't participate as much. Or maybe there really is a higher percentage of female patients and it's just not reflected in the clinics. We're not sure, but it's no matter what, it's a very high percentage female, and there are definitely some male patients. We think that, also another important point, 27% of POTS patients in the Big POTS survey reported having a diagnosis of Ehlers-Danlos syndrome. So you might think that's kind of low, because especially if you hang out on the support groups, it seems like almost everyone has EDS. But this is pretty similar to prior findings. Clinical studies done by the Shalimskys in Wisconsin, a prior survey done by Amanda Ross, who is now married and has her PhD, Dr. Amanda Miller, who serves on our patient advisory board. They had prior studies had found between 30 and 33% of POTS patients have EDS. So it's about a third. So our study found something similar. And that's people, in our study, it's people who were just diagnosed. And you could say, well, there are probably some people who are undiagnosed, and that's definitely true. We know that it's really hard for our patient community to find doctors who know how to diagnose all of these related conditions. But the studies that were done at the clinics were actual screening studies done by doctors who know how to do the screening, and they had only found about a third. So the next thing we asked about was, did you have an acute onset, like after an infection or a concussion, or did you have you just always had POTS symptoms your whole life? And some patients actually said they had had it since they were born. And, you know, the researcher said, well, you can't really have POTS when you're born because you can't walk, you can't be upright when you're born. But I think what the patients meant when they answered that way was that they've had autonomic problems. You know, probably when you're a baby, your autonomic problems might be GI dysmotility or skin blotching or temperature issues. But people, you know, people generally know when they've been sick their whole lives or not. So I feel like we should just take their word for it. The lifelong symptoms in the EDS population was 76% of patients reported having lifelong symptoms. That doesn't necessarily mean that they're going to have POTS the rest of their life. They're sort of looking backwards and saying, I've had these POTS symptoms my whole life. In the non-EDS POTS patients, 59% reported having had symptoms for, you know, their whole life as long as they could remember. So in terms of a triggering event, 39% of EDS POTS patients report that their POTS symptoms began within 3 months of a triggering event. And the most common triggering events were infection, usually a respiratory or gastrointestinal infection, and concussion. Concussion was about 10%, and infection was just under 50%. In the non-EDS POTS patients, that was just a little bit higher at 43%. So pretty similar in that regard. I think that's really interesting. If, you know, presumably you have EDS your whole life. Although we don't have a gene, we know it's highly inherited. So what was it that happened that sort of turned your EDS into EDS plus POTS? You know, if there are triggering factors for some people, then at least in those patients, it doesn't seem like the EDS itself is the thing that caused POTS. It's some sort of triggering thing, maybe blended with their EDS problem. Okay, next slide. So the orthostatic symptoms that sort of are the, you know, the defining feature of POTS, lightheadedness, syncope, tachycardia, palpitations, dyspnea is shortness of breath. That was the same whether you had EDS or you didn't have EDS. So that's pretty interesting. I mean, really, for a group of about 3,000 patients to have really the exact same numbers, whether they have EDS or not, is, I think it shows that whatever the orthostatic mechanism is in these patients, it's probably the same thing. Where the symptoms differed, one of the places where they differed was all of the GI symptoms were substantially more likely to be reported in EDS patients who had POTS than in non-EDS patients. Constipation, vomiting, stomach pain, heartburn, or gastrointestinal reflux, gastroesophageal reflux disease, technically. Dysphagia, which is problem swallowing. So that's really interesting that the EDS patients as a whole reported being more likely to have this problem. Now, our question didn't ask how severe were your GI symptoms. We were just asking whether or not you had constipation. We didn't say how often do you have it or how severe is it when you have it. That would probably be a follow-up study that should definitely be done. The EDS patients also reported significantly more symptoms suggestive of a sensory neuropathy. So skin burning, hand tingling, hand burning, hand numbness, cold hands, as well as on the next page, facial tingling, numbness, foot tingling, foot numbness, and cold feet. These were all reported more, substantially more in a statistically significant way, in people who had EDS and POTS than in people who didn't have EDS and POTS. So that's kind of interesting. Why would we have EDS patients having more gastrointestinal symptoms and more symptoms of a sensory neuropathy than the non-EDS patients? Both of those suggest a neuropathic process, because your GI tract is also controlled by your nervous system. So particularly your enteric and your autonomic nervous system. So the conclusion of our abstract was that EDS is a common comorbidity in POTS. POTS patients with EDS are more likely to have GI and sensory neuropathic symptoms. Clinicians should screen POTS patients for EDS with the Batten scale. And further research is needed to better understand the relationship between EDS and POTS. I think we all knew that no matter what was going to be the answer, because one study isn't going to fully explain everything. So there are some prior studies about neuropathic issues in EDS that we can draw on to sort of relate to this. So some prior studies showed that EDS was associated with proprioceptive and somatosensory deficits. So what is proprioception in English? It's knowing where your body is in space. A gymnast has amazing proprioception to be able to sort of flip upside down and sort of land blinded on a balance beam. People with poor proprioception sort of bang into walls, and they're a little klutzy, and if you ever sit down on the couch and you meant to sit somewhere but you ended up sitting 3 or 4 inches to the left of where you meant to sit. I do that. I have proprioceptive issues. So that's just, that's common in some EDS patients. Somatosensory deficits are similar. It's sort of your your sensations of touch and feeling or neuropathic pain. These have been reported previously in EDS. So hypermobility is also associated with a pseudomotor neuropathy, even more so than POTS itself, which is interesting because we know that, well, let me first explain what a pseudomotor neuropathy is in case there are some folks who aren't familiar with that term. Pseudo is Latin for sweat. It's not a typo. Some people try to correct us and tell us how to spell pseudo, like P-S-E-U-D-O. And we say, no, pseudo is Latin for sweat. The pseudomotor nerves are the tiny little small fiber nerves in your skin. They're not myelinated. They're very susceptible to damage when there are neurological problems in the body. And they regulate your sweat glands. So about 50% of POTS patients have a pseudomotor neuropathy. This is known from prior research. And a pseudomotor neuropathy is sort of like a small fiber autonomic neuropathy because the pseudomotor nerves are part of your autonomic system. And a pseudomotor neuropathy often occurs, but not always, with a small fiber sensory neuropathy that can cause tingling, burning, numbness. So it sort of makes sense that there were more EDS patients reporting skin tingling, burning, and numbness if there are more EDS patients who have a pseudomotor neuropathy as well. And sorry, I keep clicking the wrong button. Oh, just to go back to this, the data from the prior study on EDS hypermobility patients found that 65% of the EDS patients in that particular study had a pseudomotor deficit. They had abnormal testing on QSART, which is a lab test that they can do at some of the autonomic labs. It's non-invasive, and they're just looking to see how your pseudomotor nerves function when stimulated. So about 50% of POTS patients would have an abnormal QSART, and about 65% of EDS patients would. Curiously, about 60% of chronic fatigue syndrome patients have a pseudomotor neuropathy as well. So sometimes I think it's all of this small fiber neuropathy that really links all these overlapping conditions together, but the researchers are not necessarily in agreement on that yet. So other studies about neuropathy in EDS, there's a study that found axonal polyneuropathy in 13% of EDS patients, mainly in the patients who had the more severe vascular type and the TNXB deficient types. So what is an axonal polyneuropathy? Polyneuropathy just means many nerves, not just one nerve. And the axon is sort of, if you look down at the bottom of these 3 nerve images, it's sort of the turquoise-ish long nerve that's underneath the myelin kind of wrapping. And it can be damaged, and once it's damaged, the nerve sort of tends to die back, and it can cause some pretty significant problems in terms of your motor control and your sensory function. So that's a subset of about 13% of overall EDS patients. So the big picture is that there's a lot of neuropathy in EDS, and we really don't know why. I think we need detailed pathology studies where we take, specimens from EDS patients who are known to have a small fiber neuropathy, and from EDS POTS patients, and from non-EDS POTS patients who also have a small fiber neuropathy, and compare them. Do they have the same nerve damage? Is there something different about their nerve deficits? Is the collagen in the small fiber nerves of the EDS patients somehow different than in the non-EDS POTS patients? Collagen is part of the structure of your nerves, so that could be one potential mechanism that EDS neuropathy may occur. There are definitely other reasons that could happen. We do know that EDS patients as a whole are more likely to develop autoimmune conditions than the general population. Dr. Francomano, who's a very noted EDS researcher, had presented a paper on this, or an abstract on this, back in 2006. And we do know that some of the POTS patients who have had some of these research-based antibodies identified at University of Oklahoma and elsewhere had an EDS diagnosis and did have some of these antibodies, and a very small number of them have been able to receive immunotherapy just to see if it would help them feel better, and it has. So that sort of, in my mind, makes a big question mark. Is the POTS happening in EDS because of the EDS, or does EDS somehow make us more likely to develop whatever it is that's causing POTS? I don't have the answer yet. I would love to fund the research that figures it out, and we fund our research through donations. So if you are motivated to find the answer to this question like I am, to the extent you can, we encourage people to donate to the POTS Research Fund or to hold a fundraiser, get other people interested in fundraising and donating for research, because right now the federal government is really not funding much POTS research. They've funded less than $200,000 a year on average for the past 5 years, and that's not even enough for one study. So we're going to really try to kick it up this year. We have our first congressional briefing on October 19th, where we are Dysautonomia International, myself, Dr. Jeffrey Boris from Children's Hospital of Philadelphia, and Dr. Glenn Cook from the Portsmouth Naval Hospital. We will be presenting to Congress on October 19th and talking to them about the severity of the illness, how common it is, how complicated it is, how hard it is for patients to find care, and how desperate we are for just a little bit of research funding to get things going. We don't need $100 million a year right now. We could get so much done with just like $5 million a year. So hopefully that will happen. That will encourage some folks to get involved. And we've been developing better relationships with the National Heart, Lung, and Blood Institute, the National Institute of Neurological Disorders and Stroke, and the EDS research community has very good contacts with various genetics researchers at NIH and funders. So we're hopeful that there is going to be some progress on this. It's just painfully slow when you're a patient waiting for answers and just trying to get better. So this was my slide conclusion from the conference. I don't have anybody from Vanderbilt or University of Calgary sitting with me here, but I'm going to take a few questions that people have posted on the webinar tool. I'm going to try to answer if I can. Let's see. Okay, so here's a question. How can a patient differentiate the cause of joint pain when they have hypermobility but do not meet the EDS criteria? I don't have a clear answer for that, but there are definitely a lot of different causes of joint pain. And there are a lot of people who have hypermobility who don't meet the formal criteria. I would say to this person, talk to your doctor take a look at the Ehlers-Danlos Society's website for the new 2017 criteria and talk to your doctor about whether you might fit the new criteria or whether you fit into the hypermobility spectrum disorder categories, which sort of kind of seems to cover everything else. And also remember that there are a lot of other causes of joint pain, and so you might want to have your doctors rule those out if you haven't already. Rheumatoid arthritis, sometimes just having an old injury from like a car accident, Sjogren's syndrome, Lyme disease. There are a lot of things that cause joint pain, and I can't list them all, and I'm sure I'm sure people can think of probably 100 other ones that I haven't mentioned. But all right, next question. I will try to help. Will we receive the results of our EDS evaluation during the epigenetics study at the conference? I'm going to guess no on that, but I can ask Dr. Raj if that's something that's easy to include. I don't think they were trying to make a specific EDS diagnosis. They were just doing a Baton scale, and we can ask if they can include that. You can also find sort of a pretty easy guideline to doing a Baton scale yourself or doing it with your doctor on the Ehlers-Danlos Society's website. It's a pretty simple physical exam, and it would be good to talk to your doctor about that anyways. So I'll ask Dr. Raj if we can include the EDS data. Okay, here's a good one. I got diagnosed with EDS after taking the survey. It took an extra 3 years after my POTS diagnosis to get an EDS screening. Thank you, Dr. Abdullah. Well, we're glad Dr. Abdullah was able to help. So one of the things we're hoping to do with the survey is actually resurvey, send an email to everyone who had signed up initially and ask them, because we know that patients are constantly seeing new doctors and getting more informed about their illness by learning another diagnosis or figuring pieces of this out. And we also want to see how they're feeling over time. Do they feel better? Do they feel worse? Did a medicine help or not help? So we're hoping to do a follow-up survey, and that would be a great time to let us know that you've had a new condition, a new diagnosis. Someone's asking me to repeat what I said about concussion. I'm not sure exactly what I said, but I can tell you that was the second most common triggering event for POTS in people who reported having a trigger within 3 months. So the highest percentage trigger was a post-infectious trigger, post-infectious onset of POTS, which is but somewhere between 40 and 50% of patients, closer to 50%. And concussion was about 10%. Dr. Boris at Children's Hospital of Philadelphia did his own data analysis on his patients from his clinic, who were pediatric patients, and his concussion rate was slightly higher, I think maybe 13 or 14% of his pediatric patients had a post-concussive onset. I'm taking let's see. I'm sorry, I'm going to read this question. It's a long one. Okay, so here's a patient who had a diagnosis from a cardiologist and from an EDS geneticist and wants to know, how do you get sent to refer to a center for testing and help? So it's really hard for people with EDS and people with dysautonomia of any type to find doctors who can take the time to really sit down and learn about their condition and help them. And it's extremely frustrating. I don't have a really great answer. Based on the names of the doctors that you mentioned in this question, it looks like you've seen 2 really good doctors already. So I would follow up with them if you are not having any luck with your current treatment plan. A lot of this is definitely trial and error, trying to find a treatment that helps you the best. And what helps me the best may not be what helps you the best, so it makes it extra challenging. Let's see. Is there any research being done regarding POTS EDS patients having seizures? Not that I'm aware of. I do know that sometimes seizures are associated with people who have cardiac arrhythmias. So POTS is not really considered an arrhythmia. It's a exaggerated but normal sinus rhythm. An arrhythmia is like when you have skipped beats, or your heart's not beating the way it should. So I would talk to your doctor, your cardiologist or electrophysiologist about that if you're having seizures, and your neurologist. Ask them if they have anything that can help you with that. What is the best type of physician to diagnose EDS? I would say a doctor that knows about EDS is the best type. Most often, it's probably done by a clinical geneticist. But there are some dysautonomia experts who know how to diagnose EDS properly. You can find a list of dysautonomia experts on our website at www.dysautonomiainternational.org/doctors. That's certainly not all of the dysautonomia doctors in the world, but it's some of the better ones that a lot of patients have recommended. And another great way to find a doctor who can help is to go on the support groups for EDS or for dysautonomia or POTS and ask other patients from your area who they've seen, who's helped them. That's sometimes the best resource. Did the study look at a relationship between mast cell activation disorder and POTS with or without EDS? So yes, we did collect data on this. It hasn't been presented yet, so I can't share it. I would say nothing horrendously, tremendously exciting. We just know that mast cell problems occur in a subset of POTS patients. And it's not really clear if that has any more or less relationship with EDS than POTS without EDS. There was a study, which I'm sure a lot of you have heard of, that came out of NIH finding a genetic marker in a few people who have the overlapping diagnoses of POTS, EDS, and mast cell activation syndrome. So some of the patients took to calling this the trifecta diagnosis, and I think some people assume that everyone who has those three diagnoses must have this genetic problem. So that's, unfortunately, it would be great, it would be an easy answer if that was the case, but of course nothing is easy for us. That genetic marker was an alpha tryptase, a duplication error. So everyone has a copy of the alpha tryptase gene. Some people have too many copies of it, and the more copies of the gene you have, the more alpha tryptase your body creates, which seems to leave people more prone to allergic disorders. And so Dr. I'm embarrassed that I'm forgetting his name because he's lectured at our conference and he's pretty cool. Someone will remind me of his name. But the doctor at the NIH who did the study said, I don't know that this is necessarily the cause, because there are a lot of people who have alpha tryptase mutations, duplication errors, who don't have any allergic problem, who are healthy. The other thing we know is that for that alpha tryptase problem to be present, you have to have baseline elevated tryptase in your blood. So if you are a POTS or a mast cell patient or an EDS patient who does not have elevated tryptase in your blood when you're not having a reaction, then it's extremely unlikely that you would have that duplication error. If you do have elevated baseline tryptase when you're not having an allergic reaction, or you haven't had one like in the past day, then you might have that duplication error, and it might be helpful to ask your doctors to test for that. We know from Dr. Goodman at Mayo Clinic, who's been screening his POTS patients for a long time for a bunch of mast cell markers, he said that probably less than 1 in 500 to 1 in 1,000 POTS patients have an elevated baseline tryptase. And we know that a lot more POTS patients have a mast cell problem than that. So that sort of leads to the conclusion that the duplication error of alpha tryptase is maybe just one factor, but not the thing that's causing mast cell in all of the POTS and EDS patients. Okay, sorry, I've kind of spent a lot of time on that one. Oh, and also, by the way, we're going to have a webinar in December with an immunologist who's a mast cell expert, Dr. Andrew White from Scripps is going to be joining us in December for a mast cell dysautonomia webinar. All right, I'm going to read the next question here. So a patient is saying they have what looks like an EDS. Their doctor's telling them that they look like an EDS patient, but they don't score high enough. Is there any other way to seek a diagnosis? So I'm one of those patients too. I have a whole bunch of weird hypermobile joints, but I actually never met the EDS hypermobility criteria. Actually, when I went to the EDS International Symposium in Manhattan last year, one of the EDS researchers said to me, "Who's your EDS specialist?" And I said, "Oh, I don't have EDS." And she said, "Girl, you have EDS." Because of the way I was standing and the way I move my hands and stuff when I'm talking, I'm just really bendy. But I don't actually, I didn't meet the previous criteria. So I think what you can do, if that's your question, is go to the EDS Society's website, look for the new diagnostic criteria, including the hypermobile syndrome, hypermobility syndrome disorders, HSD, and bring that to your doctors and ask them to take a look at it. I would say from your perspective, sometimes we don't have to add the diagnosis. If you have doctors just recognizing that you have a hypermobility problem, it's not like they're denying that and saying it's not true and, avoiding the subject. So it's not always like, we don't always need to add diagnoses if we're sort of borderline or, I would just be cautious about that. Okay, got a pseudomotor neuropathy question. Who should you ask at Vanderbilt to test you for small fiber neuropathy? I would say the autonomic lab. Vanderbilt has the Autonomic Dysfunction Center. They see patients clinically and they see patients in research. And so any one of the doctors there would be the right person to ask about pseudomotor testing, which would, at their lab, be done usually through QSART. And there are other doctors, if you can't find a doctor who can do QSART, because not everyone has that equipment, you can ask a neurologist to do a small fiber punch biopsy. It's just a little poke out of your leg. Sometimes they do 3 because they want to do the lower leg, the middle, and the upper leg to see if there's a difference in the nerve density between different parts of your leg, because that can help pinpoint a diagnosis sometimes. So any neurologist can do that. Not every neurologist knows how to do that or how to interpret that, so don't be surprised if you go to a neurologist and they look at you funny if you ask for a small fiber nerve testing. And there are commercial, some of the hospitals do it in-house, like at Cleveland Clinic, they can do that and they have an in-house neuropathologist that looks at the samples. Other doctors will send it out to a lab like Therapath or a Corinthian. And it's a pretty easy thing to do. It's, it's not pleasant to get a hole poked in your leg. But if you can't get access to a QSART, I think it is important to know whether or not you have a neuropathy if you have POTS or EDS. Let's see. So the next question I got was about the Congressional Briefing. The Congressional Briefing is only open to members of Congress and their staff, and it's not because we're jerks. We know that patients and families probably would want to attend, but we have a limited sized briefing room, and our goal is to educate as many members of Congress as possible. So this particular briefing is only open to Congress. We will be recording it so that everyone can see the presentations. And it's probably nothing, we're giving Congress the basics. They would be completely confused if we tried to teach them all about it in one day. So we're giving them the basic info on what it is and how debilitating it can be, so that hopefully they will, be supportive when we ask for more research funding. Someone asked, I have a new diagnosis, should I redo the survey? So don't redo the survey on the current link because that will completely replicate your data. Wait until we email you a follow-up survey, which will ask you about whether or not you have any new diagnoses or whether or not your prior diagnoses were removed, because sometimes people might be told they have one thing and then they find out they never had it, or their doctors change their mind. Someone's asking about finding a dysautonomia expert in Chicago. So I would say try Dr. Alexandru Barboi, B-A-R-B-O-I. He is an autonomic neurologist in the Chicago area, and he has a full autonomic lab, and he's a nice guy. Let's see. Okay, percentage-wise, do you know how much more likely EDS patients are to develop an autoimmune disease than the general population? So I can't tell you that percentage for the entire EDS population, although if you can probably dig up Francomano's abstract, if you Google, I don't remember how I stumbled upon it one day. I was pretty surprised when I found it. It was like 2006, Francomano, autoimmune, EDS, lupus. Like you can find the abstract, and I think her abstract has the percentage that she found in her patients. But in terms of the big POTS survey, we asked this question. We asked questions about related, the diagnoses we see in the POTS population. Do you have Lyme? Do you have Sjogren's? Do you have lupus? Do you have migraine? Big, long list. If anyone who took the survey remembers, it was a long list. And then at the end, we said, do you have anything else? Because we knew we couldn't include every diagnosis. And I don't have the number off the top of my head, but I think I'm correct that in the overall patient population, everyone who took the survey who had POTS, it was just about 18% of POTS patients who reported having an autoimmune disease diagnosed. Sorry, that's my phone. Sorry about that. And within the EDS population who took the survey, the POTS EDS patients, the percentage was slightly higher. It was really surprising to see that because we don't normally think of, I think historically nobody has thought of EDS as, more autoimmune than general POTS is. But it might be. Oh my gosh. Sorry about that, guys. I wish I could turn the phone off. So there's slightly more autoimmunity in EDS. And I think that's a really important question we have to figure out. Why are EDS patients more subject to autoimmune disease? Why do they have more autoimmune disease than the general population? And why do they have more autoimmune disease than POTS patients who don't have EDS? I think that is really, really important question and likely to have a complicated answer. Someone is asking, is there a place where we can learn more about the role of small fiber neuropathy in blood vessel laxity? And I would say my favorite source for finding research is, especially if you don't have journal access through a university, which most people don't, I would go to pubmed.gov, pubmed.gov, and it's almost like a Google search for medical journal articles. You type in the terms you're interested in and see what comes up. So the type of small fiber neuropathy that causes blood vessel laxity is actually not pseudomotor neuropathy, because pseudomotor nerves are controlling your sweat glands. The blood vessels that control, the small fiber nerves that control the blood vessels are vasomotor nerves. So when we do a tilt test and Valsalva and the other non-invasive autonomic tests, we're indirectly measuring the vasomotor nerves. This is part of the reason why when you get a tilt test, they don't tilt you all the way up to 90 degrees, because if you did, you would stand on your feet and that would engage your leg muscles, which help pump the blood back up to your heart. They tilt you to about 70 degrees, so you're upright, but you're not really resting your weight on your feet. And that means your blood vessels, the valves in your blood vessels aren't being squeezed closed by your muscles. They're sort of wide open, and they're getting a pure measure of how well your blood vessels will constrict when you stand up, which is your vasomotor function. So some research going on at Harvard at Dr. Freeman's lab. He's an expert in small fiber neuropathy and actually invented the technique to look at small fiber pseudomotor nerves under a microscope. And so now he's trying to do the same type of technique for vasomotor nerves. So it'd be really, really cool to, besides POTS, just in general, to have a test where a doctor could take a little punch biopsy out of your leg and look and see if you have a vasomotor neuropathy. It's not done yet, but he's been doing it in POTS patients, and he told me that that it's very interesting results. So we'll have to wait for that to publish. Let me see, next question. So here's a common concern. My doctor said it wouldn't matter if I had EDS or not. What can you do for it? I would say that your doctor is misinformed. It definitely matters if you have EDS or not. Just a few of the reasons are because, one, it's inherited, which means if you're going to have children, they might have it, and you would want to know that as their parent. You might have older relatives who have had problems that could be explained by EDS. You might have some surgical complications with wound healing and sutures not working properly because of EDS. You're more prone to joint and other connective tissue injuries if you have EDS, especially because in POTS, the recommendations are that all of us should be exercising. And if you have EDS, you have to exercise more carefully. You can't just jump on any old machine and start working out. So it's very important to find out if you have EDS or not. I mean, I wouldn't like freak out about it. It's not like an urgent, big deal, must find out today kind of problem. But in general, it's important to find out. So if your doctor is telling you that, I would seek out a second opinion and maybe go on the support groups. Ask the patients in your area, where can I find an EDS expert around here? And, part of the trouble is it's hard to find an EDS expert and it's hard to find a POTS expert, and then trying to find someone who's an expert in both is even harder. So I would say, try a local geneticist or check out what your local support group patients are going to say. Okay, so here's a question that may not be EDS related, but it's a good one for me to answer. Can POTS explain dry eye and the inability to shed tears? I've had 2 negative Sjogren's tests over the last 2 years, and no doctor can explain it. So about 50% of POTS patients report dryness, either pseudomotor dryness, like sweat, not sweating in their skin, or dryness of their respiratory tract, sinuses, and eyes. In general, doctors would call that secretory dysfunction. And so that's about half of POTS patients that have that. Do all of them have Sjogren's? Probably not. But we do know that a good subset of them do. I can't tell you the exact percentage, but we're definitely interested in finding that out. When Dr. Brent Goodman from Mayo Clinic presented at our conference this summer, he actually said, which was surprising to me, he thinks that Sjogren's is actually the #1 most common identifiable cause of POTS. So I don't know if he was counting EDS as a cause when he said that. I think that he may view EDS as a common co-occurring condition, but it really hasn't been proven to be the cause. And so don't get mad at me when I say that, because some people get mad when I say it, and I don't mean it in any negative kind of way. I think we need the research to happen. We shouldn't just assume something is the cause because it's also present. Just like, a lot of POTS patients have blonde hair, but we don't say, oh, blonde hair must cause POTS. We need research that proves what's causing and what's just co-occurring, because patients really deserve the real answer, not just a good guess. So back to Sjogren's. The blood tests are negative in 40% of people who have Sjogren's, particularly in younger patients. And in Sjogren's, a younger patient is anyone who is not postmenopausal. I mean, the typical Sjogren's patient is a postmenopausal woman. So if you are under the age of 50 and you have POTS or another form of dysautonomia, you have some kind of neurological problem going on, and that makes you much more likely to have a negative blood test for Sjogren's, SSA and SSB. So the way that Sjogren's is diagnosed in those cases, when it's suspected, a doctor will do a minor salivary gland biopsy. They take a little poke out of the inside of your lip. It sounds dreadful. It sometimes is dreadful, but it heals. And that's the real gold standard way to diagnose Sjogren's. So I would encourage you to seek out a doctor who's willing to do that, and really seek out a doctor who knows how to do this. You don't want to have a lip biopsy from a doctor who doesn't know how to do a lip biopsy or doesn't know how to interpret it, because you really can't get multiple lip biopsies, maybe 2 at most. So places like Cleveland Clinic are very good at this. Dr. Shamali at Eastern Virginia Medical School has someone who does lip biopsies for him. He's my doctor who diagnosed my POTS and Sjogren's. Mayo Clinic has people who are good at this. So just try to go with an experienced center that is really experienced in autonomic disorders or Sjogren's if you're going to get the lip biopsy. And I also want to mention, I know plenty of Sjogren's patients who have EDS. So I would not, sometimes people say EDS is due to, dryness is due to EDS. Again, we don't really have any proof of that. And it doesn't mean it isn't, but we should rule out other reasons too and not just assume, you know. That's sort of my approach in general to all of these overlapping diagnoses. Sometimes we just assume, like I could assume, well, I must have POTS because I have Sjogren's. But I really shouldn't assume that because we don't have any proof. What we do know is that POTS and Sjogren's both come with muscarinic receptor antibodies that block the parasympathetic nerves that cause you to produce tears and saliva. So that might be the relationship between the two conditions. Someone is asking about what is the most beneficial research for people with EDS, and sorry, what is the most beneficial physical therapy for people with EDS and POTS? And the person says, I've read that Dr. Levine's protocol wasn't the best in this case. So I know a lot of EDS patients who have done the Levine protocol without a problem. I think you just have to be a little extra cautious with your joints. The best advice that I've heard the doctors give to patients is when you're first starting your exercise routine, you should consult with a physical therapist who understands what EDS is and the importance of making sure you don't put unnecessary stress on your joints. And some EDS patients have particular joints that give them problems. So if you're a patient who has a really bad problem with your knee, then the recumbent bicycle might not be a good exercise for you, or you'd have to somehow stabilize your knee before you did it. So it's really individualized. I would say speak to a physical therapist who has some EDS experience. Let's see. How close are they to finding a gene for EDS hypermobility type? Well, the Ehlers-Danlos Society has been working with Dr. Francomano and other EDS geneticists to, I think the first step in that was, trying to, not the first step, but a recent step, was trying to refine the diagnostic criteria to get a more homogeneous population where people have more similarities, because the prior criteria were a little loose, and so you could have a lot of people who have hypermobility but maybe don't all have the same disease. So the 2017 criteria is meant to help them get closer to finding a gene. So they'll be looking at genetic samples from people who meet the new diagnostic criteria, and hopefully that will lead to some more answers. Is there an association between EDS and costochondritis? So I don't have a formal answer for you on that, but I'm going to guess yes, because I hear about it so often in our patient groups. But costochondritis is actually fairly common even in people who don't have EDS. So I don't want to say definitively yes, but I would not be surprised. Does physical therapy help with EDS pain? Yes, if it's done correctly. In general, exercise, although it can be a real pain in the butt to get started, and a lot of us feel worse when we first start exercising, and then sort of level out over time and like your body gets a little more used to it. But in general, exercise is very good at helping manage chronic pain. It's not a magic pill. It doesn't get rid of all your chronic pain. It doesn't get rid of EDS. It doesn't really get rid of POTS. But it's very helpful if done correctly to sort of strengthen. If you strengthen your muscles, they protect your joints better, so you're less likely to have injuries. That's a really important thing to remember. So I would say, try to find a PT who knows what to do for EDS. You don't want to just start lifting heavy weights and popping all your joints out. Okay, so here's a person who says, I recently started having red spots pop up on my arms, stomach, and legs, and now my shins are covered in busted capillaries all over. Okay, this is not an EDS question, but I'm going to ask this person, if you're still listening, please go tell your doctor about this. That is not good. You know, a little bit of red spots, a lot of people, especially because there are a lot of very fair-skinned people that have EDS and POTS, it's not uncommon to have a couple of petechia, you know, little red spots, but just a few. If you have a lot of them and they're new, it could be a sign of an infection or an autoimmune problem or a very high blood pressure problem. So I would encourage you to call your doctor right away. That's definitely something that needs to be looked at. It could be nothing, but I would not wait. Is orthostatic intolerance categorized under POTS, or are they separate? I have all of the symptoms except the tachycardia. Okay, so to give a really broad overview, dysautonomia is the big umbrella term, and under dysautonomia are disorders of orthostatic intolerance, of which there are many. POTS used to be called chronic orthostatic intolerance, but then they gave it a specific diagnostic criteria and they gave it its own name. It is a form of orthostatic intolerance. In addition to being a group of conditions that are defined as orthostatic intolerance disorders, there is a specific diagnosis for orthostatic intolerance. And that is usually people who have all the symptoms but don't meet any of the other criteria for the other orthostatic disorders. So that sounds like it's probably what you have. If you have all of the symptoms of POTS, but you don't have the tachycardia, you probably have a general orthostatic intolerance. Although I would say it's definitely worth seeing a doctor who knows how to diagnose this stuff to make sure that they aren't missing anything, because there are a lot of things that can cause an orthostatic intolerance that are treatable. Let's see. A person is saying, is the Batten scale the only way to be diagnosed? She thought I said that there are no known genetic markers for EDS. So I just want to clarify, there are genetic markers for some forms of EDS, but the hypermobility type, which is the type that is most common overall and most common in POTS patients, doesn't really have a genetic marker. They're just a very small percentage of EDS hypermobility patients who have a specific tenation X gene mutation, but that's really, really uncommon. So most hypermobile EDS patients who have POTS do not have something that can be identified with a genetic marker right now. So she says her POTS specialists are disagreeing with each other on whether she has it, and it's frustrating. And girl, I hear you. It is frustrating. I would say, you know, ask the doctor who has diagnosed it to speak to your other doctors or write them a letter or call them. It's really hard to get them to coordinate sometimes, but it is important that they're all on the same page. And if you think they're not on the same page, sometimes trying to get them to talk to each other is possible. Not always, though. Milner, thank you for giving me Josh Milner's name. He was the doctor who did the EDS POTS mast cell alpha tryptase mutation at NIH. I hope he's not listening because he'll be mad at me that I forgot his name. Let's see. Our friends from Panama, Dr. Canton is asking, is there a correlation between EDS and the severity of POTS? I don't know that. We don't have the data yet to prove it, but it would make sense, I think it would make sense physiologically, that if EDS is causing or contributing to POTS or the risk of developing POTS, that a more severe EDS problem would cause a more severe autonomic problem. We do know that a very small subset of EDS patients have orthostatic hypotension, which is a more severe orthostatic disorder than POTS is. So that's my guess. I don't have an answer. I would love I would love to work with you on the research to figure that out. Let's see. Okay, I'm getting a lot of questions that aren't EDS, and I guess that's okay. I should probably wrap up though, because this was only supposed to be an hour, and I have to go. But last question here. Let's see. Let's see. Okay, is Mayo Clinic you speak of on the East Coast, or is it the one in Arizona? So Mayo Clinic, Arizona is in Scottsdale, and that's Dr. Brent Goodman. He's very good at POTS and EDS issues, and I would highly recommend him. And the Mayo Clinic campus in Rochester, Minnesota is a much bigger place, and so it really depends on who you get. There are some wonderful autonomic experts there, and then there are some other folks who are kind of, you know, good doctors in general, but maybe not specialists in this stuff. So if you, and this person is asking me, lives in Southern California, so I would try to see Dr. Ahern maybe at Scripps, or Dr. Goodman in Arizona if you're able to do that. Okay, oh, last question. Any doctor recommendation for dysautonomia in Virginia? Dr. Kamal Shamali is in Norfolk, Virginia at Centera Heart Hospital. He's a neurology professor at Eastern Virginia Medical School, and he is wonderful. Thank you guys so much for your time. I will send a webinar email to everyone with a video recording of this if you know others that might want to watch it. We will send it out with our October e-newsletter, so if you have friends who wanted to catch it and didn't get to see it, they can sign up for our email list. And then the other thing I just wanted to mention before I go is that Dysautonomia International's 5th anniversary is October 1st. It's amazing that we've been doing this for 5 years, and I feel like we've made a dent. We have a lot more to go, but we have amazing Awareness Month events all over the US and Canada, and a couple things in the works in Europe and Australia. So I'd really encourage everyone to get involved, whether you can go somewhere or if you're stuck at home. There are lots of ways to be involved with Awareness Month, and that is how we're going to make a difference. You know, we can't get research funding if no one's heard of our diagnosis. We can't get help from different social services agencies or doctors knowing how to diagnose this if we don't have awareness. So every little bit of awareness we raise really does make a difference. All right, that's it for this evening. Thanks, guys. Take care.